Hello, good afternoon. I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our multidisciplinary breast cancer tumor board. And I'm going to ask our faculty to each introduce themselves. We have some very distinguished faculty with us today. So we'll start out with Dr. Joyce O'Shaughnessy.
Joyce O'Shaughnessy, Baylor University Medical Center, Texas Oncology, and U.S. Oncology, and I'm chair of the U.S. Oncology Breast Cancer Research Program.
Hi, Terry Mamines, breast surgical oncologist. I work at Orlando Health Cancer Institute in Orlando, Florida, and also chair the breast committee for NRG oncology.
Hello, I'm Dr. Frank Muccini, radiation oncologist. I work for Genesis Care in Michigan.
Hi, I'm Dr. Maxine Chalkelson. I am the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I'm a breast imager and a PET reader.
A 45-year-old woman that has a history of left breast ductal carcinoma in situ treated with breast conservation in 2019. Subsequently, in November of 2020, she underwent a right breast reduction and was found to have mammographically occult invasive ductal carcinoma, which was grade 1, ER and PR positive, and HER2 negative. And so the question is now, with this sort of surprising finding of invasive cancer, does this necessitate a mastectomy, or can an attempt at breast conservation sort of be made? So this patient, again, in November of 2020, underwent right breast reduction for symmetry. Prior to the procedure, she had had bilateral mammograms, which were negative. She has an excellent performance status, very little medical history. She's premenopausal, non-smoker, a little bit of family history, a maternal aunt with breast cancer at age 55, and her family is of Ashkenazi Jewish descent. So again, just to summarize, in 2019, she had a left lumpectomy where she had 30 millimeters of DCIS. It was low to intermediate grade with negative margins, and she completed adjuvant left breast radiation. She declined adjuvant endocrine therapy with tamoxifen. She did have a comprehensive genetic panel, which was negative. And then in the following November of 2020, she had mammography, which was negative, and proceeded with a right breast reduction that demonstrated a 0.6 centimeter invasive carcinoma with both ductal and lobular features, grade 2, ER/PR positive, HER2 negative. The invasive carcinoma was noted to be present at the cauterized specimen edges, and so the margins were really unable to be assessed, given that this was not a planned oncologic operation. The patient desires breast conservation, and so the surgeon has ordered further imaging, and we're going to ask Dr. Jockelson to sort of walk us through that.
So this is an interesting thing, and we've seen a bunch of these lately for some reason. And I guess one thing that brings to mind, here is a young woman with a history of DCIS. Would it have been worth it to do an MRI prior to the reduction? You know, by age, her risk, therefore, was a little bit higher than an average person. So that might have been something to do in advance, but nevertheless, that's not what happened. And also the pathology did have a lobular component, which mammography is known for missing lobular carcinomas because they grow in a linear fashion. Anyway, so this is just one image from her MRI. And what it demonstrates actually, and I think the arrows, the measurements may not really match just the cancer. She does have a solid tumor in the upper outer quadrant, and some of what they're also showing going anteriorly may be part of her reduction changes as well, because when she finally had that cancer removed, it was fairly small. So this was her solid tumor, but she also has something, and again, I don't have the whole MR. I'm wondering if this non-mass enhancement or if it was seen on another image, because she had two different areas that were abnormal on the MRI. She had biopsies of both areas with marker placement, and if we go to the next slide, you can see on the mammogram, she does have a fairly dense breast. You can see that in the superior outer portion of her breast, that was the area we saw in the MRI. But then she had a second area with non-mass enhancement, and that's in the medial portion of her breast. So by definition, she has multicentric cancer. And the hard thing in this lady is just because she's had the reduction too and see the anatomy. And I haven't seen the rest of the MR, whether there's anything else, but as it is multicentric by definition.
So Dr. Mamunis, how would you approach a patient that presents in this fashion?
So that's a bit of a complicated case because obviously she had this excision with a positive margin. She has now two areas, and I don't know if this the other area in the medial aspect was proven to be malignant, but certainly if she really required breast conservation, I would definitely prove that, by doing an MRI guided biopsy.
No, it was the medial was cancer.
Okay,
Yeah.
so so she has like multicentric cancer. So I personally think that this patient is not a good candidate for breast conservation. I think she received radiation before, right, as well. So she had radiation for the lumpectomy in 2019. So even all that.
What was the other?
Only the other breast.
That was contralateral breast.
Oh, I'm sorry. Okay. So she doesn't have radiation. So if she doesn't have prior radiation and she's really motivated for breast conservation, we can attempt breast conservation by removing both areas. The upper outer quadrant is a little bit more elongated area, so it's a little bit of a challenge to get negative margins. But if, again, she was very motivated, I could discuss that with her, and removing also the area, of course, in the inner breast. So studies have shown that you can perform breast conservation for patients with multicentric disease as long as there's not much disease in between, obviously. And that will obviously be depending on the margin assessment and how much disease you find. So an attempt can be made. Frankly, though, I think that this patient has enough disease that probably she will be served better with a mastectomy and relative to the cosmetic outcome as well. And I'll discuss that with her if she was. But she was very motivated. I think one can try.
But she might have a third area because we don't know the original cancer. You have no idea where
there's a positive margin,
yeah.
right? And then she'll get radiation, of course, after that. But yeah, that's obviously the dark horse. The positive
and
margin.
Dr. Ramirez, can you comment on how you would approach her nodal assessment?
Yeah, so I think you can attempt sentinel lymph node biopsy in a patient that even had the prior reduction. There's a little bit of a rearrangement of the lymphatics, but in general, you'll be able to identify a sentinel node. If for whatever reason there is no isotope or blue dye present in the axilla, then you may have to do an axial dissection because it does have invasive cancer. But sentinel lymph node biopsy has been attempted successfully for patients that have prior breast reduction.
Perfect. Dr. Vicini, do you want to comment about the radiation? If the patient did proceed with breast conservation, how would you approach her in terms of adjuvant radiation therapy?
I mean, obviously, we'd want additional workup, additional surgery, but assuming, we got negative margins, we were confident where these lesions were, we could identify them, localize them. I definitely use, whole breast irradiation. I probably would use accelerated. And then the question would be whether or not to boost the separate areas. Obviously, she has a lot of concerns with the multicentric disease. It's not a contraindication, but it's worrisome. And so if she persisted and wanted breast conservation, we got negative margins, I would just do the conventional radiation and plus or minus a boost to both areas.
Okay, perfect. Thank you all so much.